Hello, Leah.
Hello, ma'am.
കേക്കാമോ?
കേൾക്കാം മാം. സ്ക്രീനും വിസിബിൾ.
വിസിബിൾ കർസർ കാണുന്നുണ്ടോ?
കാണാം മാം.
ഓക്കെ. ഓക്കെ. വരായി.
30 പേര് മാം. മാം ഇപ്പൊ ജോയിൻ ചെയ്യും.
ശരി. ഓക്കെ.
ഹലോ മാം, സ്റ്റാർട്ട് ചെയ്യാം. 77 പേരായി. Hello, ma'am.
തുടങ്ങട്ടെ?
Start ചെയ്യാം, ma'am.
ക്ലിയർ ആണോ പറയുന്നത് വോയിസ്?
Clear ആ, ma'am.
ഓക്കെ. എനിക്ക് ചെറിയ തൊണ്ടയ്ക്ക് ഒരു പ്രശ്നമുണ്ട്, അതുകൊണ്ടാണ് ഞാൻ ചോദിക്കുന്നത്.
കുഴപ്പമില്ല, ma'am. Clear.
ഓക്കെ. So we'll start with the retina class today. I'm planning to take 4 sessions and first talk from maybe 45 minutes. Okay. So first I will let you know the gross anatomy of the retina. That is when you look into the fundus. I'm not talking about the histopathology of the retina. In the gross anatomy, when you look at the fundus, we see the optic disc, the retinal blood vessels, the macula, and the other parts of the retina. So the macula is the most important area of the retina, which is responsible for our central visual acuity. Okay, so it is about 2 disc diameter temporal to the optic disc. So 1 disc diameter means 1.5 millimeter in size. And the center part of the macula is called the fovea, which corresponds to about central 1.5 millimeter, that is 1 disc diameter of the macula. And again within the center, so if you draw a large circle, that is the macula, the center of which is the fovea 1.5 millimeter, then the foveola, which is the central depression about 0.35 millimeter, and next is the most central part, that is the foveal avascular zone. So these are a few terminologies you frequently hear when we talk about the retinal lesions. One is the equator. So sometimes we used to say the lesions lie anterior to the equator or posterior to the equator. So the lesions which are anterior, that is in the periphery of the retina or ora serrata, we say lesions are anterior to the equator. So what is an equator? Equator is a line which connects there are 4 vortex veins which connects this exit of the 4 vortex veins. Vortex vein drain the venous drainage from the eyeball. Then another term is ora serrata. Ora serrata is the peripheral most part of the retina, where the retina and the choroid ends, which is seen as a gray, brownish black in color. Then the pars plana that extends anterior to the ora serrata. Actually, it is a part of the uveal tract. So this is the appearance of the normal fundus. Can you see the cursor, Leah? I am asking Leah because yeah, okay, because I don't know any other. Maybe I don't remember. So that is why I am calling you the representative. I want to know whether you can see or not. Okay, so this is the optic disc, what we are talking about, which is almost round, or it is called a vertically oval with a central white area. You can see this is the optic cup, and the red color, that is peripheral to the white cup, this is the neuroretinal rim, which is the most important part of the retina, optic disc, through which the retinal nerve fibers or the optic nerve fibers goes. And you can see the blood vessels which arise from the center of the optic cup slightly nasally, and which divides into superior and inferior divisions, and then inferotemporal and inferonasal, superior, superotemporal and supranasal. So this area, that is the temporal area, temporal to the optic disc, is called the macular area, and you can see there is a small area which is seen as a red color, that is called a foveal reflex, which we see it is a center of the fovea, which we can see it is a red color. So this is the right eye and this is the left eye. You can see the fovea here. So this is a diagrammatic representation of the optic disc. You can see the center, that is optic cup, and you can see this is the neuroretinal rim where the nerve fibers passes. You can see the retinal blood vessels superior and inferior, branching into supranasal and supratemporal, infranasal and infratemporal. And the darker blood vessels are the veins, and the lighter ones are the arteries. The arteries shows a linear reflex that is called a light reflex, and which is very important in the pathology. And the arteriovenous ratio is normally it is 2:3. You can see in the normal picture, this is the vein which is thick in caliber, bright red in color, compared to the arteries. This one is the artery. You can see there is a central light reflex. In the center, there is a line like that is because of the reflection of the light from the arterial wall. So that is normal fundus appearance. And what are the techniques of examination of the fundus? There are different techniques of examination: direct ophthalmoscope, indirect ophthalmoscope, and slit lamp biomicroscopy with a condensing lens, either plus 90 diopter lens or plus 60 diopter or plus 78 diopter. We commonly use plus 90 diopter or plus 78 diopter in the OPD. So coming to the direct ophthalmoscope, you may not have seen direct ophthalmoscope because in the COVID scenario, we are not, maybe you can see it in the textbook picture. In the present scenario of the COVID, we are not using direct ophthalmoscope, which is abandoned now because of the, we are going as close to the patient as possible while using a direct ophthalmoscope, which is a very high risk procedure. So we are not using it in the present. Even then I will explain because in olden days or in the pre-COVID scenario, we were using direct ophthalmoscope also. So it was invented by von Helmholtz. There is a term which is called as a distant direct ophthalmoscopy. Distant direct ophthalmoscopy is a direct ophthalmoscopy which is performed from a distance about 22 or 25 centimeter. And when we use a direct ophthalmoscope, when we see through the hole in the direct ophthalmoscope, what is happening is we are there is a light source within the head of the direct ophthalmoscope, and we are shining the light from the source. And this light, it is a complex thing within the head. It contains mirrors and prisms, and from that head of the direct ophthalmoscope, the light passes through the patient's pupil into the patient's retina, and from the retina it is reflected back into our eyes. And when it is reflected back into our eyes, we are seeing the pupil as a red color, uniform red color pupil, or any defect in the iris. If it is an iris hole or an iridectomy or an iridodialysis, anything defect, a full thickness defect in the iris, including the pupil, is visible as a red color, uniform red in color. That is what we call it as a red reflex. So when you shine this light, if you see some black areas in the pupillary red reflex, pupillary area of the red reflex, that means there may be some opacities in the media, that is either in the aqueous humor or in the lens or in the vitreous humor. So that may be a lenticular opacity or maybe a vitreous hemorrhage, or in some cases it may be part of the uveitis. So that is to identify the gross changes in the media. Second thing is, I told you, any defect in the iris is seen as a red color when we visualize through the distant direct ophthalmoscope. So we can confirm an iris hole. Sometimes if you look an external eye with a torchlight, you can see there is a black color, which we may think it is a black mole, or it may be a hole. So it helps to differentiate a hole from a mole. And in retinal detachment or in tumors of the retina also, there you can see the retina is lifted anteriorly, and you can see there is a gray reflex instead of the usual red reflex. So these are the important things which help you to diagnose using a distant direct ophthalmoscopy. One is to find out the medial opacities like cataract or vitreous hemorrhage, to differentiate an iris hole from a mole, to see the yellow reflex of retinopathy of prematurity or like that, or retinoblastoma. All these can give rise to a yellow reflex. So the direct ophthalmoscopy, it is comparable to a microscopic examination, and the defect is we can see only up to the equator. Anterior to the equator, we cannot see using a direct ophthalmoscope. So it is in patients in whom, especially in myopic patients, the peripheral retinal degeneration occurs anterior to the equator or near the ora serrata, which cannot be visualized using a direct ophthalmoscope. The magnification of a direct ophthalmoscope is 15 times. And another thing is, since we are using a single eye, that is a uniocular examination, direct ophthalmoscopy is a uniocular examination, so it will not give any idea about the depth of the lesion, or you cannot differentiate a cystic lesion from a flat lesion. So that is one defect. And advantages of direct ophthalmoscopy over indirect ophthalmoscopy is it is cheap and easy to handle, handy, and you can take this instrument very easily. You can keep it in the bag and can take into eye cams very easily. So it is mainly used for screening of the patients, especially if you want to see the optic disc in glaucoma patients. If you attend a camp, it is very handy and cheap also. So you can carry it in your bag. But if you, in cases of suspicion of lesions, in which you want to get a stereoscopic view, you have to get other alternatives. Next comes the indirect ophthalmoscopy, which we are using nowadays very commonly. And in majority of the patients, we use either 90 diopter or an indirect ophthalmoscopy. I think you have seen, we are seeing the patient with an indirect ophthalmoscope. The advantages of indirect ophthalmoscope over direct ophthalmoscope are, it has got a three-dimensional view, and hence we are using binocularly and stereoscopic view. The magnification of the indirect ophthalmoscope is less compared to a direct ophthalmoscope. It depends on the condensing lens. When we use an indirect ophthalmoscope, we are using a headband like this with a condensing lens in our hand. The power of the condensing lens is usually plus 20 diopter or plus 28 diopter, and the magnification depends on the power of the condensing lens. Suppose we are using a plus 20 diopter, the magnification is total dioptric power of the eye, that is plus 60 diopters divided by 20, that is 3. And if you are using 28 plus 60 divided by 28, that is only 2 times magnification. So if the magnification is decreased, you can see the whole retina well up to the periphery. So that is the advantage, especially if we are seeing a newborn to rule out retinopathy of prematurity, we use the plus 28 diopter condensing lens. The babies are struggling, maybe hypoxic or so many complications. So at a single point, we can see the whole of the retina. And especially in the present scenario of COVID, it gives you the patient is comfortably either lying down or sitting at one arm length, that is almost 1 meter distance. And the third is a slit lamp biomicroscopy with a condensing lens. I told you either plus 90 diopter or plus 78 diopter. It provides a high quality magnified image of the posterior pole, especially the optic disc and the macula. So I explained regarding the optic disc. Normal optic disc is pale pink, nearly circular or vertically oval, 1.5 millimeter. Margins are well defined with a physiological curve. Now I come to the investigations of the retina. One is fluorescent angiography. Just like cardiology, we are also doing fluorescent angiogram. we inject the dye into the antecubital vein and take pictures of the retina and to see the different abnormalities. It is used to see the neovascularization of the optic disc, neovascularization elsewhere in the retina, papilledema, disc edema, neoplasms, and you can get an idea regarding the perfusion of the retina. Another investigation is indocyanine green angiography. Indocyanine dye is used better to see the choroid circulation. And another thing is an ultrasonography using a 10 megahertz, which we are also performing. You have to know two types of ultrasound. One is an A scan, which is mainly used to assess the axial length, especially in patients with the cataract. We are doing IOL power calculation. You have heard about your SRK formula. One main important thing is biometry axial length. So, and along with that, you can see the anterior chamber depth and also lens thickness, especially in patients with the narrow angle glaucoma. And B-scan is another investigation. Actually, we are not from ophthalmology, we are not sending the patient to radiology department for the routine ultrasound. We ourselves are doing ultrasound scan. Only we send the patient for MRI or CT scan. So it is useful in delineating the structures behind the lens, especially if the patient has gross abnormality, like you can see whether there is any retinal detachment or intraocular tumors like that. So this is the picture of ultrasound B scan. You can see this is the anterior part. This area is the cornea. You can see the lens as a globular structure. This area is the vitreous cavity, and this black area is the optic nerve. This is the posterior aspect, and you can see there is some membranous shadow, which is the apex is attached to the optic nerve. So this is a retinal detachment. Again, you can see this is a retinal detachment. You can see these are vitreous hemorrhage, and you can see there is a globular mass which arises from the behind. This may be a choroidal melanoma. So a B scan help you to differentiate retinal detachment, vitreous hemorrhage, and a choroidal melanoma like tumors. So this is the machine of a B scan, which shown the ultrasound picture, and this is the picture of a scan also, corresponding to there is a small P is a PVD. So other investigations like CT scan and MRI also are important. And MRI is contraindicated, especially in patients with the history of injury, especially if they gives history of injury while during welding or workshop, and you are suspecting an intraocular foreign body, that may be an iron foreign body, and magnetic foreign bodies are contraindications for MRI. In such situations, you have to ask for a CT scan. Another very important investigation in ophthalmology is an optical coherence tomography. So optical coherence tomography almost gives you a cut section of the retina, just like your histopathology, and it is very useful in delineating lesions of the macula or optic nerve head analysis in glaucoma also. You can see the macular edema, you can see the macular hole, and the treatment also is dependent on the findings of the OCT. So this is the, you can see there is a line in the fundus. So the corresponding, this area corresponds to the cut section of the retina in this picture. You can see there is a fovea, which is a depression in the center of the macula. You can see different colors or different color coded retinal nerve fiber. You can see the retinal pigment epithelium, photoreceptors, and newer machines will give you almost the whole layers, and you can find out the details also. Again, this is the machine of the OCT. Now we come to the disease as such. The two important systemic disease that involves the retina is hypertensive retinopathy and diabetic retinopathy. So hypertensive retinopathy is not that important compared to a diabetic retinopathy. All diabetic patients, especially, it is very, very important to see the fundus when, especially in non-insulin dependent diabetes at the time of diagnosis itself. And in IDDM patients, once they attain puberty, you have to see, and depending on the findings, you have to screen the patient or follow up the patient. Now we come to hypertensive retinopathy. The primary response of the retinal arterioles to systemic hypertension is narrowing or vasoconstriction. So I told you the normal arteriovenous ratio is 2:3. So in patients with the hypertensive retinopathy, there occurs narrowing of the retinal arteries. So it becomes the whole retinal blood vessels, either focally or generalized narrowing occurs. And the typical findings of hypertensive retinopathy occurs if there is if the patient is not having changes of atherosclerosis, or it occurs in young patients. And there are two types of retinopathy. That is one, hypertensive retinopathy that occurs in older patients, that is with a arteriosclerotic retinopathy. And the another one is an accentuated hypertension. Suppose the patient is young and arteries are not affected, and just like in patients with a pheochromocytoma or like lesions which occurs in young patients, there occurs an accelerated progression of the hypertensive state in which the young arteries are affected and the patient directly go into malignant hypertension like stage. So the classification is by the Keith, Wegener and Barker. It is long time back the classification comes, but it is still we are following the same classification. So the classification is, I told you there are two classifications. One is the arteriosclerotic retinopathy and the other one is a hypertensive retinopathy. So in this is the arteriosclerotic retinopathy. You can see there is a mild, moderate narrowing or sclerosis of the smaller arterioles. If it comes to the grade 2, there is moderate to marked sclerosis and narrowing of the vessels, leading on to exaggeration of the light reflex and AV crossing changes. And in the third stage, there occurs a focal constriction. Instead of the generalized narrowing, there occurs focal constriction, especially at the AV crossings. So normally the arteries and veins share a common adventitial sheath, and the veins will lie underneath the arteries. So wherever the arteries crosses the vein, the arteries are thickened, it will compress the veins since it is sharing a common adventitial sheath. So arteries lie above the veins at AV crossing changes. And because of the compression, it can lead on to occlusion and leading on to retinal edema, cotton wool spots, and retinal hemorrhages. And grade 4 is all features of grade 3 along with the disc edema. So these are the pictures in which you can see there is a formation of this fluffy white material is called a cotton wool spots, that is CWS. This is arrangement of retinal edema or hard exudates in the form of a star in the macula. Macula, because of the peculiar arrangement of the retinal nerve fibers on the Hanley's layer, the exudation forms a peculiar appearance that is called a macular star. And here also you can see there are so many hemorrhages, which is called a flame-shaped hemorrhages. And if there is an arteriosclerotic retinopathy along with that, there occurs some AV crossing changes. So in the initial stage, I told you the arteries, the veins are lying underneath the arteries. So whenever the veins are crossed by a thickened artery, first thing that occurs is if the arteries are transparent or not sclerosed, you can see the veins through the arteries. So first one is a concealment of the vein or venous concealment. Second is when it is concealed or it will try to deviate, the vein will try to deviate. That is called a deflection of the vein, which is called a Salus sign. The third stage is, it is almost just like an occlusion. The arteries are compressing the veins, so there will be collection of the blood in the distal part. That is called a banking of the veins distal to the AV crossing, which is called a bonnet side. And if the arteries are very much thickened, then the veins will be like this. The arteries will cross just like compress, and the veins will be like this. That is called a gun sign, just like gun. It is a gun sign. And lastly, you can see there is a silver wiring of the arteries. And the third stage, it is called a copper wiring. Copper wiring means because of the thickened blood vessel, arteries look like a copperish appearance or copper wire. And in the fourth stage, it is a silver wire appearance. So that is about a hypertensive retinopathy. So when you have asked about hypertensive retinopathy, you have to classify it as a hypertensive retinopathy occurring in patients without any involutional sclerosis and in patients with involutional sclerosis and without involutional sclerosis. And if it is occurring without involutional sclerosis, it occurs as a malignant hypertension. That is, you have to draw the pictures in 4 stages, and final stage you can have to draw the disc edema or optic disc edema bilaterally. So this is the next one is a retinal arterial occlusions. So the central retinal artery is the branch of ophthalmic artery. It is the terminal branch of the ophthalmic artery. So I told you eye is the only structure. We call eye a window to systemic disease. So eye is the only structure where you can see the blood vessels directly without cutting or without injuring person. So it will give an indirect evidence of systemic diseases occurring like atherosclerosis or diabetes or other systemic diseases, like so many systemic diseases, sarcoidosis. And other than that, you can get an optic disc edema in the form of a papilledema. So retinal arterial occlusion is just like other myocardial infarction or like that. It is a sudden happening that occurs. So the etiology is usually atheromatosis related, and though there occurs a thrombus at the lamina cribrosa from where it gets dislodged, or you can get from a carotid artery, you can get a embolism, or even from the heart in patients with the valvular heart diseases. So patient presents with a sudden, painless, profound loss of vision. So it is an acute onset. So you may get a question on central retinal artery occlusion. Either you have to draw the fundus picture or you can get causes of sudden painless loss of vision. One important cause for sudden painless loss of vision is central retinal artery occlusion. So the visual acuity is very severely reduced except in patients with a cilio-retinal artery. There is a small artery in 20% of the patients which supplies the macula radius. That is blood vessels comes from the short posterior ciliary artery. That is called a cilio-retinal artery. So if the patient has got a cilio-retinal artery and that patient develops a central retinal artery occlusion, the cilio-retinal artery is spared and the patient can have a central tubular vision. Okay. So on external eye examination, you can get an afferent pupillary defect. So in cases of an acute central retinal artery occlusion, patient presents with a sudden painless loss of vision with a profound or total afferent pupillary defect. So this is the fundus picture. If you remember the previous picture of a normal fundus, you can see instead of the normal caliber of the blood vessels, these are the veins, which are also very thin, and literally you cannot trace any arteries. So arteries are even absent. That is, it is constricted so much that it is not visible. And you can see the entire retina, if you remember, The previous picture, that is the retina is described as pale pink in color. This retina is, the whole retina is white in color with a central small area through which the thinnest part of the fovea through which the normal choroid is visible. That is called a cherry red spot. So cherry red spot is nothing but a normal choroid is visible through a thin area of the central part of the macula. If you remember the previous picture, the central part of the fovea comes like this. It is a very thin. So here you can compare. This is the abnormal retina. And you can see there is a small area of red color that is in patients with here I cannot show you. There is a retained, there is a normal cilioretinal artery in this patient. So the other part of the retina in which the central retinal artery supplies is white in color, but a small strip of the retina which supplies the macula is spared because of the presence of a small cilioretinal artery here. So the large arteries are thread-like and smaller arteries are invisible. The whole retina is opaque and cherry red spot at the macula. So this is another appearance which is not visible in the picture. That is a cattle truck appearance if the occlusion is partial or if there is a recovery. The prognosis of central retinal artery occlusion is poor because the patient's retina cannot withstand the loss of blood supply for even for a few minutes, and the patient develop consecutive type of optic atrophy. And in contrast to the central retinal artery occlusion, there may occur a branch retinal artery occlusion. So branch retinal artery occlusion occurs in one branch of the retina. So this is another magnified picture of a central retinal artery occlusion with a cherry red spot. So in this patient, you can see again a cherry red spot in the macula. And in this patient, you can see only part of the retina is white in color. This is a branch retinal artery occlusion. So these are the normal areas of the retina. And if you see, this is also normal. If you see carefully, you can see there is a small white material in the artery, branch retinal artery. So this is an inferotemporal branch retinal artery, branch of central retinal artery. And you can see there is a small white material here, that is an embolus, which blocks the circulation further beyond. And you can see the area beyond this is white in color. Can you see? Anybody can respond. So there is a small embolus occluding the, in this patient also, you can see there is a optic at the optic disc itself, there is an embolus, and this embolus is responsible for the whole white area and the cherry red spot. So again, this patient, you can see multiple emboli. You can see one large embolus here. You can see a large embolus here, and maybe an embolus here which occludes and producing a cherry red spot. So it gives an indirect clue that this patient at any time, because of the multiple emboli in the retinal arteries, the patient can have at any time can develop other complications like myocardial infarction or CVA. Any artery may be affected. So if you say central retinal artery occlusion prognosis, it is not only the visual prognosis, it is the prognosis of the life or life expectancy, we usually used to say. So whenever you see a patient with a central retinal artery occlusion, it is a dire emergency. There are very few dire emergencies in ophthalmology. One is a central retinal artery. I come to the management later. So what all investigation if you see a patient with a central retinal artery occlusion? So I told you the emboli are released from the heart, especially if the patient has got atrial fibrillation, maybe a complication of mitral stenosis or other valvular heart disease. So you have to simply look for the pulse, whether it is irregular. Look for the BP, it is common in hypertensive patients. You have to feel for the carotids, whether the carotids are occluded or whether you can see, whether you can feel the carotids normally or it is feeble. Compare with the opposite. And whenever that is the basic dictum you studied in MBBS, that is, don't palpate the carotids bilaterally. Okay, that can lead on to syncope. Okay. So ECG, you have to look for the blood routine examination along with the FPS and a lipid profile, because all these are very common in diabetic patients and hypercholesterolemia also. So the treatment. So what is the treatment? When you see an embolus and a central retinal artery occlusion, the treatment is, you say, or we used to say, the treatment is, even though I have written it, is less than 48 hours as early as possible. So like any other vascular accidents, usually these patients comes with a history of sudden loss of vision on waking up in the morning. So treatment is as early as possible, and better if you treat it within 48 hours. Even if the patient comes later than 2 days or 48 hours, we treat, because the treatment is very simple. And we have experiences that patient recovered even after 48 hours. So taking a chance also is important. So I always used to ask my colleagues and PGs and residents, whenever the patient comes, even if it is after 48 hours or after 72 hours, give the treatment, because the treatment is so simple. It can be done in the OPD. We are not doing any much thing to the patient, but saving vision. I had patient who recovered to 6/36 after 72 hours. So because of that experience, I always used to tell them. So what we are doing is relieve spasm, or I have shown you a major branch, or the at the disc itself, there is a embolus which is sitting at the lamina cribrosa or at the origin of the central retinal artery. So what we are doing is, we do procedures which suddenly dilates the retinal artery, either central or branch retinal artery, and this embolus is led from the main trunk of the central retinal artery to a peripheral branch, so that only a part of that area visual field is affected. So relieve the spasm or drive the embolus into less important branches by simply massaging the eyeball. You just massage the eyeball with 2 index fingers, as if you are just doing your digital tonometry. Just with the 2 index finger, continuously massage for 5, usually we 30, 30, 30. That is 30 times we massage, 30 seconds release, then again. So that will produce a decrease in the intraocular pressure. So whenever there is a sudden decrease in the intraocular pressure, there occurs a vasodilatation. So so that is a very simple thing, digital massaging. Second thing is do paracentesis, that is take out some aqueous humor from the anterior chamber. Again, that produces a sudden lowering of the intraocular pressure. So paracentesis. So when you do massaging, it should be done before paracentesis, because if you do paracentesis and then massage, then the patient will have iridocorneal touch and like that. Okay, another treatment is inhalation of amyl nitrate or IV acetazolamide to decrease the IOP, or to produce inhalation of the amyl nitrate produces vasodilatation, which is not available in, I don't think it is anybody is doing here. So that is the end of the class, today's class. I think I will continue on Wednesday. Any doubts you can ask. How many students are there in your batch, Leah?
Ma'am, 118.
So 82, only 82 has entered.
Ma'am, some of the students are there in YouTube. Labor room posting ഉള്ളവർക്ക് range ഇല്ലാത്തതുകൊണ്ട് അവർ യൂട്യൂബിലുണ്ട്.
Okay. So you can give me the attendance of both.
Okay, ma'am.
Any doubt? Because it is a very boring, retina is a very boring topic, and it is in online class Zoom, it is also very difficult to demonstrate also. Otherwise, if it is in the real platform, I can draw the pictures, or anyway, you can get a few questions like drawing fundus pictures of central retinal artery or hypertensive retinopathy. Even short note of 3 marks can be asked. Any doubt? You can. Otherwise, I will stop. Anybody? Shall I stop?
Okay, ma'am.
Okay.
Thank you, ma'am.
Okay. Bye. Take
Thank
care.
you.
Thank you, ma'am.
Okay.